This mini lecture is going to be on macrocytic anemia, and we're going to cover folate deficiency also. Macrocytic anemia is defined as anemia with a mean corpuscle volume that is equal to or greater than 100. So these anemias are typically normochromic. They may be normoblastic or they could be megaloblastic with large erythroid precursors. Macrocytic anemia has four categories, so we're only going to talk about a couple of them, which is the vitamin B12 deficiency, and then we're going to talk a little bit about the folate acid deficiency. Pernicious anemia, though, is a major form most often seen in the older population, and it is caused by a hereditary autoimmune disorder where there is destructive antibodies against the intrinsic factors. And these are, there's some different factors that are involved with it, but these are the proteins that are produced by the gastric parietal cells that bind to dietary vitamin B12 or your cyanic or your cobalamin during the digestion. Under normal conditions, the dietary vitamin B12 is really cleaved from the carrier proteins in an acidic environment of the stomach, but it then rapidly binds with cobalamin binding factors. And then this is what is found in the gastric secretions and in the saliva. It is essential to the maturation of the erythrocytes, which do convert to homocysteine, and there's a subsequent decrease in gastric acid production compounds, vitamin B12 deficiency, because cobalamin in itself cannot be freed from its carrier proteins in the less acidic stomach. Thereby, what happens is then the subsequent binding of the intrinsic factors in the duodenum occur. So this is really considered an autoimmune disorder, and it results in the malabsorption of B12, which results from the lack of that gastric intrinsic factor, and that's usually because of atrophic gastritis. It can also be associated to chronic alcoholism as well as H. pylori bacteria infection, and then the long-term use of antacids and the H2 receptor antagonists as well as protein pump inhibitors. And then patients also that are on a metformin, long-term use of metformin, risk being vitamin B12 deficient. Dietary deficiency is kind of rare because of the rich supply in animal proteins that most people have, because meats and dairy products are the only dietary source. So vegetarians may be at a higher risk of getting a B12 deficiency than someone who does ingest meat and dairy. For the history, these patients may present with complaints in history of complaints of having some psychiatric issues. So they may have some irritability. They could possibly have mild memory or cognitive impairment or even depression or psychosis. They may have had a history of gait disturbances, could be jaundice. They may have some paresthesias in the extremities, and also would have a history of involvement in the upper and lower extremities as well as hand symptoms, and they would definitely present with a history of a sudden onset of symptoms. So it's really important in this group that we go ahead and get a good thorough history on these patients. When we're getting their history, looking at their medication history, how long have they been on metformin? How long have they been on any of the GI products? So the antacids, the PPIs, the H2 receptor antagonists, and then past medical history. Have they ever had a gastric surgery or gastric bypass? Have they had Crohn's disease? Had they have a Whipple procedure done? Do they have any type of hypofertility, repeat miscarriages? Some venous thromboembolic diseases, or even a history of angina. And then looking at social history, what are they, vegetarians? Because that, as I said, is an increased risk if they're a truly strict vegetarian. And then these people with chronic alcoholism, we need to ask them about their alcohol intake. A lot of these patients present with, when you do the physical exam, you may see that they're jaundice, that they have that smooth surface tongue. It's very kind of beefy red and shiny, and they may come in and just tell you that their tongue is sore. Also, dry and cracked inner surface of the mouth. You could find an ejection murmur with them. Tachypnea. They may have some diffuse abdominal tenderness with no organomegaly. They also may have some frequent polyneuropathies, have some ataxia, and even some changes in the Babinski sign, and even a positive Romberg. They may have some irritability, mental irritability with status changes. And so, diagnostically, what are we looking at with these patients? Well, initial testing involves confirmation of the megablastic macrocytic anemia on a blood smear. So, you can expect the findings, which include anemia as well as an elevated MCV level. The MCH level should be within normal limits, as the anemia is usually normocytic. So, when we're looking at the parameters to diagnose B12 deficiency, we look at the B12 levels. So if they're less than 74, if they're less than 150, but they have some type of clinical evidence of disease, do they have serum levels between 74 and 295 plus one or more of an elevated MLA level or an elevated serum homocysteine level? Do they have a serum holotranscobalamin level that's low? Or do they have any history of renal failure? Because they should, in the apps, it's usually absent in renal failure or folate deficiency or even a vitamin B12 deficiency. Now, the homocysteine and the methylmalonic acid levels really can distinguish between two etiologies, which both values being elevated in vitamin B12, where the homocysteine levels are more elevated when you see a folic acid deficiency. But common to both of those is a high serum iron level and findings that could be consistent with a mild hemolysis, like a low haptoglobin level, an elevated LDH, and some elevation in the bilirubin. Their reticulocyte count will be low, and as well as an abnormal peripheral smear, but their folate level would be normal. They also may have some anti-intrinsic factor or anti-parietal cell antibodies that can definitely diagnose anemia. The Schilling test is rarely performed today, but it was really used to diagnose GI malabsorption in B12 deficiency. And what that was they orally administered radio-labeled vitamin B12 to measure the ability of the small intestine to be able to absorb that B12, which is then subsequently secreted in the urine. So there was like a two-stage step on a 24-hour urine collection that had to be done as they looked at those measurements. Okay, so then we're going to think about the management of these patients. They can be given oral B12, they can be given IM B12 or intranasal B12. In most cases of pernicious anemia, and especially if there are neurological symptoms, more aggressive therapy is usually warranted for these patients. So, in these patients, giving them parenteral 1,000 micrograms of B12 IM daily for 1 week, and then they get it once a week for a month, and then they get it once a month for life. So that would be in severe cases. Usually we start them out orally about 1,000 to 2,000 micrograms a day if we're going to give oral dosing. If they do have the folic acid deficiency, then you would prescribe, folic acid, and we'll talk about that again in a few minutes. If the cause of vitamin B12 deficiency is not pernicious anemia, but then you need to look at some other different things for prescribing. So the oral cobalamin until the serum levels are achieved in usually about 6 to 12 weeks. High doses of these may even be effective in some cases of pernicious, but it just depends on what the GI absorption is. But daily therapy does require that they are committed to doing it, as well as compliant for doing it. So follow-up on these patients, they really should be seen about 5 to 7 days after initiation of therapy. And you may see that the homocysteine and the MMA levels do start to fall within a few days after you do start it. So you should be referring them if you do suspect that there is severe anemia or even a nephropathy that's involved with this. Dynamed recommends lab testing with a CBC 5 to 8 weeks after starting therapy to confirm the response, and then blood tests annually for early diagnosis. So doing a CBC, doing a thyroid function test, checking their glucose levels, all of that should be done. As we look at folate deficiency, this is a critical nutrient that acts in concert with vitamin B12 to further the nuclear maturation in erythrocytes. So this does lead to decreased levels of tetrahydrofolate, which is a really important building block of DNA. And as with the vitamin B12 deficiencies, these abnormal erythroid precursors deficient in folate are prone to some intramedullary hemolysis within the bone marrow. So this also leads to that characteristic anemia, which it really is indistinguishable clinically from a vitamin B12 deficiency. So when you have reduced folate levels in the red blood cells or serum, then that is what is considered your folate deficiency. It is usually caused by an inadequate dietary intake. Alcoholics and anorectic patients are also at a high risk for this happening. And some drugs can interfere with the absorption. So the dilantin drugs, the phenytoins, as well as the sulfa drugs can also interfere with the absorption. When pregnancy occurs, then the requirements are elevated that the folate levels are needed more in that state. And they should be given supplements before and during pregnancy because this does reduce the incidence of neural tubule defects. And the recommendation is 0.4 milligrams daily. And this has made a significant change in the neurotubule defect of in pregnancies when women are given this since this has been introduced. When we're looking at the history of these patients, they usually have kind of similar to a B12 deficiency where they feel fatigued and they don't want to eat. They've got stomach inflammation. They have a low-grade fever. They may also have a little jaundice, but then the anemia may also present with weakness and lightheadedness and pallor. So as you can see, the symptoms are very common in both diagnoses. Less common causes of folic acid deficiency are impaired metabolism and storage of folate, and the liver typically stores enough folic acid to serve the body's needs for several months, as long as hemolysis and increased erythrocyte production are not any issues. So that would be something like in sickle cell anemia. There are many causes of impaired folate metabolism and hepatic storage. Chronic alcohol results in the decrease of that, as well as dilantin, as I said, and the Bactrim. But the folic acid deficiency really contributes to a variety of mechanisms. So you may see absorption in other causes, such as tropical sprue or Crohn's disease and some intestinal problems. As far as medication history, the folate antagonists are your methotrexate and your primethoprim and trimethoprim and triamterene. Oral contraceptives are also something that needs to be looked at when these patients have folic acid deficiency. So we want to ask them about their alcohol intake. We want to get a thorough diet history. We want to ask them about their dietary sources of folate and about folate supplements that they're taking, including any multivitamins that they might be taking. Physical, you might see the same thing that's going on with somebody who has a B12 deficiency. So the glossitis as well as the pallor and the hyperpigmentation. For folic acid deficiency, looking at the folate levels, anything less than 7, that may not accurately represent it, but the red blood cell folate levels less than 305 would be pertinent, as well as your MMA and your total homocysteine. So these differentiate a little bit from B12 deficiencies because there would be a normal MMA with the elevated homocysteine, and that would indicate folic acid deficiency. Management, when we looked at Dynamed, is to ensure that they're getting folic acid 1 milligram orally a day, and that usually replenishes in 3 weeks. The effects of therapy really should be reassessed after 2 to 3 months. It's critical to understand that treatment of these deficiencies can reverse many of the hematological defects that you do share with vitamin B12 deficiencies. So ruling out vitamin B12 deficiency before starting a folate replacement is important to do, especially in patients who are pregnant. Follow up, checking your CBC about 2 weeks after you start the treatment, and you should see an increase in the hemoglobin and a decrease in the MCV. And you should see really good hematological response within 8 weeks of treatment.